Thank you, thank you. Thank you, AOP Bhavnagar and organizing team. Thank you, Anand sir, કે જેમણે શિફ્ટ કર્યું. એઝ એ પિન ચીટર બેટ્સમેન, જેમ 2020માં છેલ્લી 2 ઓવરમાં 25 રન કરવાના હોય એવી રીત તો મને ટાસ્ક મળ્યું છે. તો લેટ્સ સી. I promise that whenever buzzer will ring, I will step down. Okay. And for next 15-20 minutes, my motto is to highlight the importance of hormone which is there in our body. So what are the hormones? Hormones are natural chemicals produced in our body, which is produced from one organ, travels via blood, and they act on another organ. If hormone is not there, we are not what we are. Whenever we are in our mother's womb, sex steroid decides our gender. After birth, ખેંચ આવે તો PTH, ભૂખ લાગે તો ગ્લેરિન, ધરાઈ જાય તો લેપ્ટિન, ઊંઘ આવે તો મેલેટોનિન, ઊંઘ ઉડી જાય તો ડોપામિન, પ્યુબર્ટી આવે તો સેક્સ સ્ટીરોઇડ્સ, રિપ્રોડક્શન કરીએ તો ઇન્હિબિન બી, અને ગુજરી જાય ત્યારે પાછા ગ્રોથ હોર્મોન. So from intrauterine life till death, we are decided by hormones in our body. So life without hormones will be just like this robot. We don't have gender, maybe ambiguity, no growth, no puberty, no emotions, no love, no sex, no reproduction. So hormones which are make us humans. And it all starts from the intrauterine light. If it is XY, then few genes on the Y chromosome decide the growth of testis, which is ultimately producing testosterone, and it's a male. If Y is absent, both are XX, it is the development of Mullerian structures, ovaries, estrogen, and it is phenotypically female. If there is any of the problems in this axis, we will have a problem, and the term is called disorders of sexual differentiation. So if any baby is born and you have ambiguity regarding the deciding gender of the baby, it is called DSD, but now the word is changed and we should call it atypical genitalia. So if any baby with ambiguous genitalia is born, first you need to examine. If gonads are palpable within the scrotum, whether scrotum is bifid or normally developed, it is 99% testis. So if gonads are present and you do ultrasound, in ultrasound there is absent of Mullerian structures, then this is probably 99% XY DSD. If gonads are absent, Mullerian structures are present, this is XX DSD, and the most common cause is being congenital adrenal hyperplasia. So without doing any fancy investigation, if you just understand the physiology, you need to rule out almost 80 to 90% of the disease, and this is the most confusing part. And as we know that the atypical genitalia is social emergency. મમ્મી પપ્પા તરત પૂછશે કે સાહેબ શું આવ્યું. પહેલાં કોઈ એમ નથી પૂછ્યું હેલ્ધી છે નથી છે, રોયું નથી રોયું, કેટલા કિલોનું, પહેલાં શું પૂછે સાહેબ બાબો છે કે બેબી. સો ધીસ ઇઝ સોશિયલ ઇમરજન્સી. વેધર it is atypical genitalia, you should be very careful in deciding your words. બાળક છે આવ્યું છે, નાન્યતર જાતિ યુઝ કરવાની. બાળક આવ્યો છે આવી છે તો પેરેન્ટ્સ માઇટ થિંક કે આ તો બાબા બાજુ ઇશારો કરે છે કે બેબી બાજુ. And then you need to carefully explain that first we need to do USG, we'll send karyotype, and then I will be able to exactly decide the gender of the baby. So with this physiology, learning lessons is proper examination, look for palpable gonads, and do USG for Mullerian structures. On the day one, there is no hormonal requirement to be done, just do USG, and there is no role of MRI as well. So palpable gonads means thorough examination, and ultrasound will do the most of the work for you. And there is soon after birth, hell lot of changes. Baby is dependent on mother for all the things, whether it is glucose, whether it is calcium, whether it is thyroid, or whether it is any other things which are nutritionally important. So after birth, cord is cut. So first of all, insulin is shut down. Second, all the counter-regulatory hormone increase to provide glucose to the baby. So if insulin is not shut down, there will be neonatal hypoglycemia. And this is called congenital hyperinsulinism. And this is present in many of the babies, like infant of a diabetic mother, those babies who are born to SGA, extreme prematurity, and perinatal stress, like meconium aspiration syndrome, perinatal asphyxia, or early onset sepsis. So if low sugar, you need to do all this hormonal workup where sugar is less than 50, and it is called critical sample. So in critical sample, the most important is insulin, cortisol, growth hormone, along with ketones as well as lactate level. After this, what happens? There is a TSH surge. And as we know, after birth, the baby is in cold stress because intrauterine temperature is 38-40 degree and baby is delivering into the cold weather. So there is heat generation by TSH, and this is called normal TSH surge. TSH typically surges and get down by 72 hours of life. And this is the reason we don't need to do TSH before 72 hours of life. If at all you would be able to do cord blood TSH, that is fine, but there are many issues. So definitely TSH after 72 hours of life is nowadays a rule. Almost all the governments recommend it, and being a private pediatrician, we at least should write down the TSH after 72 hours of life. In premature babies, this surge is prolonged, so TSH might be normal after 72 hours. So in all premature babies, you should do TSH at the time of discharge or preferably second to third week of life. For this PTH, again, baby is dependent for calcium from the mother. So whenever cord is cut, there might be chance of hypocalcemia. And to prevent this hypocalcemia, PTH from parathyroid gland rises. So if there is hypoparathyroidism, the baby will have neonatal hypocalcemia. So the thing is, clinical point is, within first 72 hours, if the baby develops hypocalcemia, it is not due to vitamin D deficiency, but it is due to PTH. So neonatal hypoparathyroidism will lead to neonatal hypocalcemia. So at birth, all these hormone changes occur, and this is the reason of most important complications of the NICU graduate. So we'll start with a case. A baby comes at day 2 with the TSH of 32. So being TSH so high, the baby started on treatment, but gradually developed tachycardia, weight loss, and on follow-up after 2 weeks, baby had undetectable TSH with high T4. So confusion whether we treated was right, but again, as we know that the hypothyroidism is the preventable cause of mental retardation, ideally we should treat, right? So what is wrong? Can anybody tell? We did a high dose or any other thing get wrong? Before 72 hours. Okay, any other guess? Okay, let's see. We'll see after physiology finish. A case to a 9-day-old neonate who was born 28 weeker with the weight of 1.4 kg, on ventilator, on respiratory distress syndrome. Septic screen was positive, TSH was normal, so he was reassured. And again on follow-up, developed mental retardation with the TSH of 20 on 2 months of life. So this is also a case where first TSH was normal, it was reassured, and then again the TSH risen to hypothyroid level. So what is happening? As we know that the thyroid gland is controlled by TRH and TSH, which controls the thyroid gland. But there are catch. One is called fetal thyroid. Fetal thyroid is very quiet. Fetal thyroid does not produce enough T4. So during intrauterine life, fetus is dependent on mother for the T4. But TSH does not cross placenta. So if maternal hypothyroidism is untreated and the baby has absent thyroid, then there are chances of intrauterine severe growth retardation along with mental retardation. Another thing is called post-neonatal surge, which I already described. And third is called sick euthyroid syndrome. See, thyroid is a catabolic hormone. So whenever we are into some illness, the thyroid gland shuts down. So there is a picture of low TSH and low T4, just like central hypothyroidism. So my advice is don't do thyroid function tests while the baby is in crisis or ventilator or general condition poor. Whenever baby is settled, then and then you should do thyroid screening. And out of this, edema, protruded tongue, hypotonia, and prolonged jaundice, which is the most common symptoms you have observed? So the most common symptoms of congenital hypothyroidism is no symptom. Baby might be absolutely normal. That's why newborn thyroid screening is advocated in each and every newborn. And after 72 hours, our own IAP guidelines say you can do after 48 hours as well. So if during first 48 hours, if it is less than 34 or after 48 hours it is less than 20, it should be considered as normal. So the dictum is more than 40, urgent treatment, less than 20, no treatment, 20 to 40 plus minus. You can do free T4 or you can refer to endocrine. So this is our own IAP guidelines on day 3. On day 21, it should be below 6. So this is the protocol. So if TSH is less than 20 on day 3, no need to repeat, no need to worry. Otherwise confusion will occur. Another thing, we can skip this. So our first case, the baby was started treatment on day 2 with the TSH of 32. So this TSH is absolutely normal. This TSH was done early. So don't do TSH in first 2 days of life. That is the message. Our second case, this is a classical case of sick euthyroid syndrome. So this TSH was normal because of the baby's condition. Baby is on septic screen, baby is on ventilator. Ultimately, you should do repeat thyroid function test while the baby gets settled, and preferably at the time of discharge. So all SGA, all NICU graduates should have repeat thyroid function profile testing at the time of discharge or within first follow-up after 3 to 5 days of the discharge. So this few are the thyroid, you can say, guideline-based recommendation. The TSH after 3rd day of life, less than 20 is normal. So 15-18 આવે તો ટેન્શન નહીં લેવાનું. You are absolutely right. Many a times we think કે ભાઈ આપણે કંઈક મિસ નથી કરતા ને એટલે આપણે ઓવર ટ્રીટમેન્ટ કરીએ છીએ. But less than 20 TSH is absolutely normal. ઘણી વખત પહેલા વાલી સવાલ કરે કે સાહેબ આ નોર્મલ રેન્જમાં તો 5નું લખ્યું છે. But we can explain then, this is for the adult and adolescent. For the newborn, 20 is normal. And third is 20 to 40, you should go for endocrine opinion. Maybe you do free T4, maybe you do USG thyroid, and that's it. So this is regarding the thyroid gland. Quickly, I will touch base on the diabetic part as we have less of a time. And hypoglycemia. So approach to hypoglycemia is, first and foremost important investigation is you should look for ketones, because we have very few conditions which can cause hypoketotic hypoglycemia, and that are hyperinsulinism, fatty acid oxidation defect, and galactosemia. So beta hydroxybutyrate is the most useful investigation as far as the hypoglycemia is concerned, and nowadays we have ketone meter which is also available. So every department or every critical care setting should have this ketone meter. Whenever baby's sugar goes below 50, first you do bedside ketone. If the ketone is negative, the only investigation you need is serum insulin level. Any detectable insulin in presence of hypoglycemia is suggestive of hyperinsulinism. And believe me, 90-95% cases of neonatal hypoglycemia are hyperinsulinism. In case of ketotic hypoglycemia, most important are the all storage disorder, glycogen storage disease, gluconeogenic defect, and organic acidemia. And last one is hypopituitarism. Because in hypopituitarism, 2 hormones are missing, that is cortisol and growth hormone. So these 2 combined deficiency can cause hypoglycemia. But in all this, you will have high ketones, because ketone is the second mechanism by which brain gets energy. So hypoketotic hypoglycemia, do insulin. Ketotic hypoglycemia, then you need to find lactate, organomegaly, and then growth hormone and cortisol. So this is the algorithm of hypoglycemia. There is no role of giving hydrocortisone without documenting cortisol deficiency. So if there is resistant hypoglycemia, don't give hydrocortisone unless and until ketotic hypoglycemia is present. In a way, if you have low ketone, you can start diazoxide trial if there is hyperinsulinism, and rest target blood glucose is 70 or above, not the 40 or above. So these are 2 clinical points in the management of hypoglycemia. And with this, I want to rest my case. Thank you for patient listening. Thank you.